Perez, who will be talking about diversity in medicine. She is a professor of cardiology and one of the leading experts in cardiovascular disease in women and patient-centered healthcare advocacy. She provides strategic guidance for Northwell's diversity and health equity initiatives and serves as the health system's first chief diversity and inclusion officer. Under Dr. Mraz's leadership, Northwell Health has been recognized as a top health system for diversity, equity, and inclusion. She has authored more than 70 scientific publications, has presented her research at over 100 national and international conferences, co-produced 4 documentaries, and has co-authored 3 books, including Heart Smarter for Women and Reigniting the Human Connection, A Pathway to Diversity, Inclusion, and Health Equity. So welcome, Dr. Mraz.
Hello, everyone, and thank you for that kind introduction. And I had a chance to listen in on the last speaker. So this talk is a little bit different. I'm a cardiologist who practice clinical cardiology, nuclear cardiology for about 25 years or so, doing research on women's cardiovascular health, and then transitioned about 15 years ago to focus on healthcare redesign, on bringing in the aspects of diversity, inclusion, health equity into into how we deliver healthcare. So truly with the goal of making the patient as a partner. And, as Ronnie told you, in healthcare, you have many options, right? You can, beyond just becoming a doctor, nurse, multiple options, including becoming a healthcare administrator, as well as doing multiple other things. So this talk will be about 30 minutes or so with Q&A to introduce you to the concept of how we are changing healthcare for the 21st century and sharing with you some of the things we have done at Northwell. I've had the honor and privilege of being part of a team to do so. So it will be a quick run through in terms of helping you think of what is needed for healthcare as we approach the third decade of the 21st century, and why the components of health equity, and we'll talk about what that means, which includes, diversity, inclusion, sort of taboo words at this time, why this is critical in healthcare for improving health outcomes. Feel free to stop me along the way if as questions arise. So let me just optimize the screen for, for sharing. 1 second. I'll be right with you. Okay, perfect. So I've titled the talk Improving Health Outcomes for All and the Importance of Health Equity. So as you think about this, what I'd like you to do is so today's talk we'll talk about a quick introduction, why the need for health equity strategy in healthcare, and some insights into what we have done at Northwell. And hopefully you'll walk away thinking of, yourself and your family members who have had to navigate the healthcare system, because we're all going to be patients one day, and why in the concept of the patient as a partner is so important. I always joke and say, and my team and colleagues say, that the quest for health equity is like the climb to Mount Everest. And if you ever have attempted or you've looked at people who have climbed Mount Everest, you meet truly unexpected conditions. And I think that changing healthcare to embed all of these components is akin to the climb to Mount Everest. So let's take a quick look and think about the fact that we're all going to be patients one day. You're young, you probably haven't really navigated the healthcare system, but I'm sure you've had family members. And let's think about what that entails and why we truly need to, call for change to get the components of health equity into it. So we think there has been a national call for an expanded model of healthcare delivery to include patient-centered partnership and equitable care. And if you follow the news and seeing Snapshot just highlighting some of the publications since COVID-19 that have called for this redesign of healthcare to build in components of diversity, inclusion, health equity, cultural awareness, language awareness, health literacy, the why for that. And this was one of my favorite infographics from the former Commissioner of Health, Dr. Robert Califf, a fellow cardiologist. And he said that COVID-19 truly is like a tsunami. It unmasks lots of the healthcare disparities and the fragmented healthcare system. And he says that we as a world have not yet adjusted our healthcare system to deal with the the epidemic of chronic diseases. And we know chronic diseases include cardiovascular disease, and that we are, like a tsunami. And if you ever know what happens with a tsunami, it comes and then horrible effects, catastrophic effects happen, that we are, if we do not change how we deliver healthcare, we will definitely not improve health outcomes and we'll have shortened lifespans. And he listed a host of reasons. And when you look at the data, we know that in these United States, life expectancy has been shortening compared to other countries. We know that there are disparities in who gets to live longer. And we know that our healthcare system is fragmented, and that we really have to truly change how we deliver healthcare to truly account for the determinants of health. And he suggested interventions. We know a lot depends on lifestyle. Like somebody has high blood pressure, you see your physician, your nurse practitioner, the physician's assistant, you get a prescription, but 80% of what will happen depends on your lifestyle in addition to taking your medications. And another recent publication in 2024, again, calling for healthcare redesign, a portrait of the failing US health system, highlighting the fact that the US lags considerably compared to 10 nations in life expectancy and how we deliver healthcare. We go back to the archives, and I'm just sort of giving you a little bit of background information, that we see that at the turn of the 21st century, many of you were not here then, yet born, the Institutes of Health gave us 6 pillars and a roadmap as to how we should change healthcare. That healthcare should be efficient, it should be effective, so efficient, it should provide scientific knowledge to all who can benefit, it should be safe, avoiding injuries to patients, it should be timely, that you shouldn't have to wait months and months or wait in the ER for a long time. And 2 new pillars were added, that it should be patient-centered and it should be equitable, because the equity piece came based on the publications that based on socioeconomic status, gender, race, and where you live and your zip code, that not everybody benefits from the life-saving strategies. So really calling for embedding equitable healthcare into our health systems and how we deliver care. And then finally, that really the thought and the sort of template for healthcare, that we should treat each individual patient as a partner. And in any partnership, it means that you have to embed into the treatment plan what matters to that person and their life circumstances. So the thought of recognizing the diversity of individuals and serve as partners in their health is really critical. We think of what is the impact of chronic disease and why we need to change healthcare delivery, a national concern. You see here in this infographic that 6 in 10 of adults in the United States has some chronic disease. And we think of what are those chronic diseases? You see heart disease, you see cancer, you see chronic lung disease, strokes, diabetes, kidney disease are all chronic diseases. And these were diseases probably 5 or 6 decades ago were fatal. And now, because of advances in technology, they're chronic diseases. And we still have not changed how we manage chronic diseases. And that is critical if we are to improve quality of life and outcome. You could see that 4 in 10 adults have at least 2 or more of chronic diseases. And when you think of what are the lifestyle changes that are needed, you could see that, exercising, how we eat, nutrition, smoking, all impact the ability to live a long, healthy life. And a call for what goes into health, and this is something you probably haven't been thinking about, what goes into health. We in healthcare are only responsible for 20% of health outcomes, but health behaviors, the physical environment and socioeconomic factors, education, job security, financial security, all impact one's ability to live a long and healthy life. And so I want to share with you, as you think about this and why culture and language and health literacy and where you live are important. I want to share with you a quick story of this gentleman, Kevin, that we had the chance to hear his lifestyle and what was happening with him from Alaska. 2015, over a decade ago, we produced a documentary called RX The Quiet Revolution, where we were looking at communities across the United States and how communities were taking charge of their health and becoming true partners in governing how, members of their community lived. So here's the story of a quick snapshot of this 45-year-old Alaskan man, 10-year history of type 2 diabetes and hypertension. You could see here, and I know you're not in medical school yet, or you can see his vital signs. His blood pressure was elevated at 140/90. We aim for 120/80 or less as normal. His waist circumference was 38, meaning that he had a lot of abdominal fat in the waist circumference. We aim for an waist circumference half of your height, and a BMI, body mass index, a rough index to say how your weight is distributed, was 28.3, and 25 or less is normal. He lived in rural Alaska with a wife and 2 kids. The nearest clinic was 50 miles away, and he had a high school diploma. So I want you to just listen for the next 3 or 4 minutes to his story and be thinking of how culture and lifestyle can influence our chronic diseases.
When my mom was 8 years old, she boarded an airplane and she left our community for the first time in her life, and she went to a boarding school along with all the other children. And while she was at boarding school, she was told never to speak a Chupik word, so she had to only speak in English. I asked her, what would happen to you if you did speak a Chupik word? And she said, well, all the children who spoke Yupik and Chupik had duct tape placed over their mouth, and they were lined up in the classroom as an example to the other children not to speak Chupik. And I always looked at it as something all the children went through until I heard an elder in Bethel tell me about the grief that the adults experienced because the village no longer had children in it. All the children were gone. And this elder told me that the whole village fell silent. And the trauma of that, I think, is the beginning of understanding where the domestic violence and sexual abuse comes from.
Today, the amount of violence among Alaska Native people is staggering. The physical and sexual assault, neglect, and mental abuse of Native Alaskan children is more than twice what it is in the rest of the country. And more than twice as many Native Alaskan women are victims of rape than women in other parts of America.
And so we're going after all those who have been harmed and those who are doing the harming. We're not victims, we're not survivors, but we definitely are people who have been harmed. And we have harmed. And so we have been addressing that all and believe it's the root causes of much that has happened in Alaska.
They stripped us of our culture, and that trauma was instilled in us. When I was abused, I was told not to talk about it. That's just the way it was. And so we kept silent. And one of the lies we learned as men, and it's every culture that says this, men don't cry. Men don't ask for help. Well, those are lies. Men do cry. Why do we have tears? Trauma in a person's life eats you up inside when you keep that story bottled in. I was holding in all that anger, all that hate, all that resentment spiritually, and it was eating me away. I mean, I've got high blood pressure. I've had become pre-diabetic. Just look at the rate that our people are committing suicide and the domestic violence that's in the communities. We have to talk about it.
To all who suffered at the hands of another, come out from the bitterness, come out from the shame. Well, the
The women dance a dance called Rise Up Mighty Warrior, calling out Alaska Native people to break their silence.
turn to those with love who have only brought you pain. So rise up, mighty warrior, rise up.
We hold 5-day intensive trainings where people share their story for the first time. 8,000
Oops, sorry. So this was just an example to show you that, you know, and Rick's story highlights the fact that in treating someone, the culture is really important. And this was just a snippet. And when we had the opportunity to speak to, you know, the members of the Nuka health system, this was a community that was definitely accepting the fact that some of the cultural trauma and all of the linguistic challenges definitely affected their ability to get diseases. And so this is just an example to show you that lifestyle changes, determinants of health definitely have an impact in controlling chronic diseases, as he had hypertension and diabetes. And when we followed up years later, you know, understanding that he was a partner in his health, helped control blood pressure as well as his diabetes. And so as we think of health and all of the factors that influence someone's outcomes, humanism, the dignity and respect, health literacy, being able to communicate, definitely important. And importantly, how you live your life and one's spiritual beliefs, perceptions, attitudes, definitely affect one's ability to adhere to a medical plan. And when you go if you decide to go into the practice of medicine, whether you're in whatever aspect, and you're dealing with patients, dealing with communities, recognizing that all of these factors will influence someone's ability to stick to a treatment plan. Things that are patient related, their level of literacy, so how we speak to our patients, how we truly partner with them to take medications or change lifestyle stories. For us at Northwell, we have a population, at least 50%, that has a preferred language other than English. So being able to communicate in their preferred language is really important in fostering that partnership and having someone stick to a treatment plan. The cultural beliefs, side effects of medications, lack of involvement in the treatment decision, and cost of medications are all factors we have to think of when we're treating people for any chronic disease or any disease that's related. There are other factors that we have in the healthcare that we're changing, you know, really fostering improved communications. And you could see some here that all of these factors can affect somebody's ability to stick to a medical plan. The time you wait in the office, limited access to care, all of these, and fragmented care, all can affect individual outcomes. And so truly the national call for healthcare delivery redesign to improve outcomes for chronic disease is based on the growing number of adults with chronic diseases, the fact that we recognize that social determinants of health impact the biology of disease. And here you see, and this is a complicated slide, but it's just to show you a framework that people who live in or suffer from economic instability, food insecurity, live in certain environments, and where there's chronic psychosocial and environmental stress, that all of these factors affect the inflammatory system of the body, leading ultimately to the development. It affects the bone marrow, the chromosomes, the liver, all organs are affected. And this is evolving science to show that that leads to the development of cardiovascular disease, some of the other chronic disease, because of buildup of plaque in the vessels. It leads to obesity, hypertension, and many risk factors that predisposes one to get cardiovascular disease. So truly a schematic to show that lifestyle and where you live, all of these factors affect the development of inflammation and leading to chronic diseases. So as we think about it, and we have spent a lot of time, and this is going on at health systems and academic centers all over the world, what do we need to do to have people live longer and healthier lives, healthy at every stage in life? And the model for improving health outcomes, and we look at cardiovascular disease, I'm a little biased as a cardiologist, is that quality healthcare is only achieved through a partnership between patients and their families and the medical team. And so the quest for health equity, or improving health for all, linking to improve outcomes, has to do with customization of care. You may have heard the terms equality and equity, and this infographic from the Robert Wood Johnson Foundation highlights the way to think about this. So equality, so we say in this infographic, everybody gets a bicycle, but the bicycle is the same and it's not customized to anyone. You can see the person in a wheelchair not even able to do the race. The person who is about 6'5" gets a bicycle that's fit for someone that's 5'5" or 5'3", and you can see the challenges. The little girl gets the same bicycle as the adults, and really the only person here that could truly complete the race or have a chance is this, woman that's 5'5" and can sit comfortably. That is equality, and the equation is that equality is like you give everybody access to healthcare, but giving everybody access to healthcare alone will not improve outcomes. And so equity, the term that was invented, highlights the fact that care needs to be customized based on your individual needs. And so the quest for health equity is one, and I call it the Holy Grail, that ensures that all people have full and equal access, as well as the opportunities, that is the customization that will enable us all to lead healthy lives regardless of their background. And so truly the call, and especially after all of the challenges we face with COVID-19, an expanded approach to healthcare delivery to deal with chronic diseases. And this is an infographic and a highlight that shows you, and this again, lots of my theme is on cardiology because that's how I spent most of my career. And it shows you the tale of two patients. And this is a schematic of a beating heart that we look when we image people. You could see the coronary arteries running right and wrong. And this is a rendition or a remodeling of what the heart looks like. Very often chronic disease, it builds up in the arteries. If you have diabetes, hypertension, sedentary lifestyle, smoking leads to, and we now know some of those other factors of psychosocial stress, living in an environment where there's a lot of smoke or environmental toxin, affect the lining of the arteries that can lead to a heart attack. And this is just to show you the impact of some of the determinants of health. Patient 1 and patient 2, and this was published a few years ago, born the same time, lived in two different areas. And you see patient 1, educated, insurance, health, truly aware of what's going on, trust in doctors and the healthcare system, lives after even having coronary artery disease and a stent placement, 76.7. Patient 2, same age, but has challenges with employment, food, lives in a food desert, suffers from food insecurity, stress of life. He works 2 or 3 jobs, not sleeping, really stressful, and not truly getting, access to all of the care that he needs. You see that social determinants of health could definitely cause one person to live 4 to 5 years shorter than a person who has access. So this is really just to highlight the impact of what can happen to 2 patients based on where they live and all of the determinants of health. Recognizing that we need a new focus and an expanded approach to healthcare delivery, in 2011, the first ever U.S. National Prevention Strategy was published. And you see here 4 key areas that are needed to increase the number of Americans who are healthy at every stage of life. We need healthy and safe community environments, clinical and community preventive services, people need to be empowered. So you need patient education and understanding the disease process, as well as a focus on elimination of health disparities. And you see here that when you have the knowledge and we customize care based on one's needs, whether you can afford the medication, whether you need to come back or have telehealth visits to understand where you are, check in more regularly, that truly this is not intractable, that we can really give people the opportunity to live longer and healthy lives. And that health outcomes are widely based on a bunch of factors. But we could definitely have a focused approach when we use the equity approach or advancing health for all approach, customized care based on one's needs, that we can definitely truly achieve the holy grail of increasing the number of Americans who are healthy at every stage of life. You put this all together, and as you think about this, if you've ever navigated the healthcare system, a redesign is really important. And if we think of the patient as a partner, this infographic highlights that in the old days, the patients, it was the medical team making all of these decisions. You put the patient in the center. If you're in the center, you really don't have as powerful a voice. Whereas the ideal model is that the patient and family need to be part of the healthcare team, providing information to help customize care that's needed to improve their overall outcomes for them all to live a healthy and long life. And you see here, all of these pieces will lead to us as a health system, as a nation, making sure that everybody can really live a long and healthy life, and control for chronic diseases. And all of the factors include understanding the community, humanism and dignity and respect, cultural awareness, social determinants of health. All of these factors, effective communication and language access, need to be incorporated into the treatment plan if we are to truly achieve a state where everyone can live a long and healthy life. And for us, our definitions of what we mean by diversity and inclusion, and definitely now thinking of those terms as really the mosaic of all different backgrounds and lifestyles and perspectives that people bring to the healthcare world. And fostering inclusion has to do with cultural respect, access to opportunity, a sense of belonging, that this is needed for a trusted partnership. So what have we done at Northwell in the past, 15 years or so since we have been on the journey for expanded healthcare delivery? We opened a new medical school about 15 years ago, and there was a need for an advanced curriculum that truly, in simple terms, had the understanding of the patient and families as part of the healthcare team. And so a medical school, which is definitely a very contemporary curriculum, or medical students become trained as EMTs early in the first few months of medical school. We're about to have a new class right now. And there was a need for us to come up with a true formalized approach to healthcare redesign, to embed the tenets of inclusion and health equity into our healthcare delivery model. This is just a quick schematic that it has been an evolving framework. The need and the why for it has to do with, as I mentioned before, we serve a population where 50% of our population has a preferred language other than English. If you look at it in terms of how you partner with our patients and communicate what's needed and customize care. And we came up with a framework that truly was with our mission to advance the delivery of culturally inclusive healthcare and effective communication in partnerships to achieve health equity and to ensure that everyone had a chance of a long and healthy life. These were just our leadership pillars, and you can see there continuous education, the leadership commitment, which came from our CEO or dean of medical school, the dean of a nursing school, or dean of our PA school, community partnerships, or Northwell team members are actively involved as employee resource group, helping us to accomplish this mission, or community partnerships, really critical, and a focus on gender disparities and women's health with the Katz Institute. We've now evolved to truly say that quality care must be equitable care. And we are have revised our framework to say that, or to advance care for all, it has to be our patients, our communities, and our team to get to that page. And I highlight that as a nation, we know that disparities in healthcare truly cost billions of dollars. And each year in the United States, we spend over probably close to $30 billion due to healthcare delivery disparities. And that's why I say it's the climb to Mount Everest. And that eventually, even though, we have had to re-look at how we do things in this space, it definitely will become an important part to improve the life and health of all Americans. And so we come back, and this is our Northwell approach. It's our patients, our teams, our communities in advancing health for all. We're including all of the components of you see on the cogs there, and our community health piece and understanding what our community needs at all levels is critical to this. Teaching cultural awareness, really having healthcare information and patient education available in about 21 to 25 different languages. Information for people who are deaf, hard of hearing, or visually impaired, part of our healthcare team, and truly delivering care, incorporating the social determinants of health, and truly treating everyone with dignity and respect. Having research where we have representation of all members, the mosaic of lifestyles, of lived experience, including in research, all critical for us to definitely advance health for all. And truly the continuous education of patient education and team education, critical for us to change healthcare where everyone at every stage of life has a chance to lead a long and healthy life. This is just a quick highlight of our framework, and you can see here with our patients, we're bringing an advancing healthcare delivery lens to everything we do. We are looking to make sure that everyone has the opportunity to have care customized based on their social needs. So we're screening for social needs and social determinants of health. We have screened over 1 million patients so far, making sure that effective communication is important, universal language access, and then truly delivering culturally responsive care in partnership with our patients. As a health system, we're focusing on 6 areas of focus and 6 disease states to eliminate and address healthcare delivery disparities. We're looking at sepsis, readmissions, maternal mortality, and you may see that these are part of the national framework, looking at depression, hypertension, and diabetes, chronic diseases that with a focused approach could be controlled once care is customized. And it has been quite the journey. Along the way, we're measuring what we have done. Progress has been made in this space. The journey continues. And we are looking at feedback from our communities that yes, they're feeling that truly that we are delivering culturally responsive care, that we're partnering with them. They have input into how we deliver care, and we've gotten some accolades along the way. So this was just a quick snapshot to highlight what we at Northwell has been doing in expanding care for the 21st century to deliver culturally responsive care to our patients in partnership. We now have evolved to the Advancing Health for All model. We truly remain committed to making sure that all members of our communities could see us as their trusted partner and have a chance to live a long and healthy life at every stage of life. So this was really a quick snapshot of what we're doing and why this is definitely important. So I will stop sharing and answer any questions at this point in time.
Awesome. Thank you, Dr. Merez, for your fascinating talk. I'm sure our brain turns took away a lot of valuable insight. So now we can open the floor to questions. So we have a few come in already. The first one, what is a key takeaway from your book, Heart Smarter for Women.
Oh, good, which I did. So, the key takeaway from the book, and thank you for that question. My colleague, Dr. Stacy Rosen, and I, and or dietitian, Marissa, as well as some of the team members, Lori Russo, we have been on a mission to answer questions from our patients. And I'll tell you just a little bit of the catalyst and the reason for the book. Many of our patients would say, okay, we understand the science, we have seen it, but we need actionable items as to what we can do to truly control and decrease our risk of heart disease. So we set out to write the book based sharing stories from our patients in simple language. And one of the key takeaways is that 80% of heart disease can be prevented. And by lifestyle changes. So we have given the 6-week approach of how to choose a heart healthy diet to make sure that you control your blood pressure, to make sure you control your cholesterol. We highlight the importance of many of the risk factors. Of course, we know to stop smoking. We highlight what you need to do in terms of sleep and stress, because those are new areas where we know that it affects the inflammatory system and leads to, risk factors for heart disease. We also importantly highlight the power of movement, and we demystify exercise. You think of exercise, we tell you don't have to go to a gym. You can get 30 minutes of activity in aliquots of 10 minutes or 5 minutes every day. The American Heart Association says we need 150 minutes of exercise per week. So we give you steps to do that. And whether it's walking, jogging, dancing, racing, bicycling, just choosing to be active every day is really critical. And we highlight the studies that show how activity decreases your blood pressure, controls your blood sugar, decreases your risk for heart disease. And one other important, so we give you the steps you need to do on your own to control heart disease, to prevent heart disease for you and your family. And the other thing we do is really highlight the power of partnership. We say that you have to be proactive when you go for your doctor's visit, whether you're seeing your nurse practitioner or the physician's assistant, that you need to take an active role in the discussion with your medical team so that care can be customized for your need. But the overarching theme is small steps equal big changes in preventing heart disease for you, your family, and all of your loved ones. So I hope that answers your questions and gives you a little bit of insight that, for many chronic diseases, changing your lifestyle, exercise, putting down the salt shaker, avoiding smoking, finding time. We also highlight the importance of laughter, yoga, stress reduction, critical to controlling your risk for heart disease.
Thank you. Yeah, that's such an important takeaway. Someone else asked, as a first-year medical student, what steps should I start taking to strengthen my chances of matching into a cardio residency,
Oh my goodness.
particularly in terms of research and electives?
So I would say, doing research, definitely, whether it's clinical research, in the area of cardiovascular disease, definitely important. So you have to realize that to get to your first, as a medical student, you finish medical school, you're going to have to do an internal medicine residency. That is the first step. So it's 3 years of internal medicine after medical school. And it's really in your internal medicine rotation that, doing those 3 years, making known that you're interested in cardiology is critical for the match. So I would say in medical school, to explore to see whether you want to become a cardiologist, doing one of your electives in a cardiology rotation will give you great exposure as to what being in cardiology involves. And cardiology is a huge profession with, you could do clinical cardiology, preventive cardiology, imaging in cardiology, where there's nuclear echo, cardiac CT, there's electrophysiology, the electrical system. So I would say medical school, the important thing is to finish medical school, but taking an elective in cardiology is definitely useful.
And sort of in that same vein, what initially drew you to cardiology and what keeps you passionate about your work today?
So my journey into cardiology came from a personal story of losing my grandfather when I was age 7. And my grandfather died of a massive heart attack, and I was told it was hardening in the arteries. And I was very close to my paternal grandfather. And I made a vow. I became very curious about science and made a vow to go into, to understand how the heart works. Along the way, I got a little bit sidetracked. So grew up in Trinidad, then came to go to college in at Bennington, did their pre-med program, and then went to Boston University for medical school. And you realize you get into medical school, you're exposed to myriad opportunities, myriad specialties. But I was just still, the story and just personal losing my grandfather kept me focused on understanding how the heart work. And luckily at medical school, I had a chance to do a rotation with Dr. Alice Jacobs, who a female cardiologist, interventional cardiology, who truly became one of my mentors, and saw how spent time with her and became even more fascinated with the heart. And then in training, started to do a little bit of research. So I was always intent on becoming a cardiologist, although I loved OB because delivering babies was amazing, but the personal story kept me rooted there. And then I would say the transition. So I did research. Women's cardiovascular health was important to me because I was seeing how there was a difference in who left the hospital after a heart attack or who was enrolled in life-saving clinical trials. Very often women would come in, it was too late because they didn't understand their symptoms. And we have now discovered women have a myriad of symptoms, more so than men, that present as heart disease. Yes, they'll get chest pain, but there are other things that are precursors or other symptoms that we had missed in the medical community. And I recognized that women were not eligible for some of the life-saving trials. So I became fascinated with doing women and cardiovascular disease, and was lucky enough in terms of imaging to write the imaging guidelines for the American Heart Association. Volunteering with the American Heart Association also continued to keep me passionate. And then the opportunity to truly expand from looking at gender disparities to looking at healthcare as a whole, and trying to solve for not only gender disparities in cardiovascular care, but trying to change healthcare so that we can not have any disparities is still what keeps me passionate. And so the opportunity to be at Northwell and truly, under the leadership of our CEO, Michael Dowling, or Dean, that was Larry Smith at the time, now David Battinelli, our Chief Medical Officer, Dr. Jill Kalman, and others, committed to doing the work of improving care for all, is what keeps me passionate.
That's awesome. Thank you. Um, Someone else asked, so as the author of several books and producer of several documentaries, how have you seen storytelling shift public perception or policy in meaningful ways?
100%. And I'll tell you, I was inspired, and my colleague and I, we were inspired, Dr. Stacey Rosen, to sort of venture into documentary production and writing books by a patient of ours. And we, probably over 2 decades ago, met a patient who was a documentary producer, and she introduced the concept of, she said, in healthcare, you see your patient for, probably what, an hour at times. If you're doing a test on them, you have limited interaction, and then you send them away. You make a diagnosis and you send them away with a prescription of things to do. And she said, there's a disconnect here because people relate to stories, and people need to be inspired to change their lifestyles and can only do so and will do so more effectively when you can relate to someone. And so that was an interesting concept. And I'll tell you, the American Heart Association definitely adopted that concept because they have made storytelling a critical part of increasing awareness. And so this patient, and Barbara Paskoff, who was a documentarian, said, come join me. Let us travel around the country and hear stories of how people were conquering heart disease or feeling defeated by it. And I'll tell you, once we started doing that and you look at the results of the formalized campaign of the American Heart Association, which I'm intimately involved with, Go Red for Women, we see that, and I'll tell you the statistics because we've measured it, the power of storytelling in raising awareness, as well as all of the other awareness campaigns, whether it's on television and magazines or whatever, has women who are aware and have heard stories or can identify with someone, at least 90% of them were inspired to make some heart smart change, whether it was talking to their doctors about their risk for heart disease, critical, tweaking their diets or their eating styles to be a little bit more heart healthy. That the numbers there were about 70% of the over 1 million women who were involved in Go Red made one or more change to improve heart health. So I would say the power of storytelling, truly, truly powerful. I want to just go back to highlight one of the things that we have learned scientifically about heart disease in women. We have known, and we have this in our book, Heart Smarter for Women, that women who have had pregnancy-related complications, such as hypertension, gestational hypertension, preeclampsia, diabetes, the birth of a small infant less than weight, or eclampsia, these women are now at risk for heart disease about 5 to 15 years later. So in all of the research we've been doing, and we've included this, when pregnancy-related complications is definitely a risk factor. And so one other thing in the book, we encourage women to talk about if their pregnancy history with their doctor to determine their risk for heart disease. But again, and using the power of storytelling of what have happened for women, and this is an evolving area of research, has definitely been a catalyst for women when they see their OBGYN or even their family doctor, more importantly, their family doctor, to do a risk assessment for heart disease and mention any pregnancy-related complications. So storytelling is definitely powerful, where we as human beings are inspired when we see someone that looks like us or we can relate to their story. And that has been instrumental in raising awareness and the fight to conquer heart disease.
Wow, yeah, that's really an impactful way to drive change in cardiovascular health for sure. Um, we had another question asking about your perspective on how AI might shape cardiovascular surgery in the future.
So I'm not a surgeon, but I would say AI, but in imaging, AI definitely help, right? And we've been using sort of machine learning to help us. And in my field of nuclear cardiology, cardiac imaging, to quantify, you use visual analysis, but using machine learning programs to quantify the percentage of the heart that was at risk. I would say more importantly, AI would be an additional tool, and you'll have to speak to the neurosurgeons and many of the surgeons who use it in helping us define, with diagnosis, with treatment strategies, that AI could definitely be useful. Want to highlight the importance of wearables and wearable techniques, especially in the fight for heart disease. The Apple Watch, the Fitbit, all of these factors we have found as the American Heart Association have studied this, have been useful in getting people to choose to move every day, to stay on a treatment plan. We know in terms of wearables for blood pressure that we can more easily identify people who may have white coat hypertension versus who are truly hypertensive. So I would say wearables are definitely here and now and useful in controlling risk for heart disease, giving us insight into diagnosis. And in terms of AI, truly, I think will be and will continue to be useful in helping us come up with treatment plans, co-create treatment plans that will work for patients, but also important in diagnostic assessment of many, many diseases.
Yeah, thank you. Another question is about how students and aspiring physicians can start advocating for health equity early on in their careers.
So, great question. We have a little bit of a challenging time, as you read the news and the term health equity has definitely been challenged, right? Research on health equity has been a little bit of a standstill. I think, and for us, we're looking at, okay, how do we evolve some of the work we're doing? Because clearly, a customized approach, and when you think about it, health equity is truly customizing how we deliver care to include the determinants of health and all of the factors, your culture, your spirituality, all of that into the treatment plan. Truly the concept of the patient as a partner and co-creating a treatment plan that works. So I think the way to think about it and to discuss it is truly under the auspices of recognizing that 80% of health outcomes is other than the medical encounter. We account for 20%. We see our patients for a limited time, we make a diagnosis and we send them on their way, and then they come back months later and maybe the blood pressure is out of control. So we have to have the narrative of this is, if we are to make every person have the opportunity to have a long and healthy life at every stage of life, care needs to be customized. And in terms of customization, we have to understand what goes into health. And so you think about the definition of health equity, or that diagram I showed you, the infographic with the bicycles. I think we have to frame the language of the one-size approach to healthcare delivery doesn't work for all, and truly foster the concept of the patient as a partner and customizing care. So truly expanding the narrative or simplifying the narrative to talk about customization of care based on our patient and their needs, if that helps or makes sense.
Yes, that makes perfect sense. Thank you. And we have one last question. So when it comes to a large health system like Northwell, how do you measure success in when it comes to diversity and equity initiatives?
So I would say, so we've been on this journey for 15 years or so, and we have, come up with a strategic plan, and you saw the pillars, right? We're looking at our patients, our teams, our community. You look at how we measure success for our community, and our community Institute for Community Wellness and Population Health, led by Dr. Deb Salas-Lopez, they've definitely had a health equity task force with the community, and CARE has definitely, we have taken that information, what the community needs in terms of care, to bring it back to the health system, right, to customize care. And I'll give you an example. Recognizing that literacy was a problem, access to jobs in healthcare or jobs as a whole as a problem. One of the metrics or in different zip codes, a mentorship program was started, as well as we are opening as a health system our first healthcare-based high school based on a huge grant from the Bloomberg Foundation opening later on this year. So access to more people from certain zip codes who are, vulnerable communities have access to healthcare opportunities and jobs is definitely one methodology. And that was measured based on feedback from the community task force. When we look at success from our team, we look to see whether our team members are coming from a community and whether we are meeting the needs of the community or whether we are reflecting the communities we serve. And that has been followed, and we've done team member surveys to understand whether, some of the components Do they feel the sense of belonging? Do they foster inclusion? So we have formalized approaches to inclusion and belonging as part of our core values or value system. And we look at employee surveys, like our Press Ganey survey, to see whether our team members are feeling that they're included or belong, which is a core component of the overarching diversity and inclusion. And we have seen those numbers go from like 30% when we started, now up to probably in the high 80s%. We have more work to do. So that is one indication. And in the clinical space, looking at are there disparities in care, we looked at, and one example we measured, if your preferred language was other than English, would you have to wait longer if you came to an emergency room to get care, to be triaged, compared to people who spoke English? And earlier on, we found some discrepancies, right? That there was at least a 50% greater wait time if your language was not English. And we have changed that to make sure that when you come in and in partnership with our communities, you highlight what is your preferred language, what is the language you speak at home, and you have access within a short period of time, and the entire team knows this, to have access to someone, whether it's by on a video or on a tablet, to someone who speaks your language, so that communication could be enhanced. And we have found that the time to get treated has gone down significantly. We're not perfect as yet, but a significant decrease in time to treat. So those are 3 examples of how we measure whether we're making an impact in how we deliver care and truly solving for healthcare delivery disparities.
Awesome. Well, with that, we will wrap up our session today. Thank you, Dr. Mrez, for sharing your time and insight with our brain turns. I'm sure they learned so much. Let's give a big thank you in the chat.
Thank you so very much. And if I can help in any way, and I would say, as Ronnie said to you, you have great futures. Healthcare is a great field, multiple things to choose from being a healthcare administrator, a healthcare coordinator, even, at Northwell, or food services are now state-of-the-art and chef-based, right? We have a Michelin star chef overhauling so there are multiple areas to be involved in healthcare, whether it's research, teaching, the traditional being a doctor or nurse, physician assistant, social worker, speech pathologist. Healthcare is a great field, and I encourage you all to consider it. So with
Awesome.
that,
Thank you so
enjoy the
much.
summer. Happy to be here. And congratulations to Zoe, Vader, and the team for a great, great session. Thank you. Honored to have been with you today. Bye-bye.
Thank you so much.